everyone, and welcome to my channel. So we have started the CVS from pediatric subject, and we have discussed the tetralogy of Fallot and the TGA, which are both okay. These are discussed already, and we have discussed the tetralogy of Fallot and transposition of great arteries, which are both the cyanotic heart disease. In this video, we will be discussing the ventricular septal defect, which is a cyanotic heart disease. So we are having a scenario that there is a 6 years old child comes to OPD for the treatment of his diarrhea. He has no dehydration and vital signs are stable. On auscultation, his heart there is pensystolic murmur which has no relation to respiration or change of the position. Parents are not aware of any heart problems in their son. Another scenario is that there is a 1-year-old male infant with the history of failure to thrive and recurrent chest infections since birth. On examination, his weight is 6 kg. He is having tachypnea and tachycardia but no cyanosis or clubbing. On chest examination, there is pansystolic murmur at the lower left parasternal border and loud P2. He has bilateral basal fine crackles and hepatomegaly as well. So, guess the diagnosis. Another scenario is that there is a 1-year-old toddler brought in distress in emergency. He has history of recurrent chest infections since birth. Mother told that she used to tired early while feeding. On examination, temperature normal, weight 7.5, respiratory rate 55, pulse 140. On inspection of the chest, there is Harrison sulcus and subcostal and intercostal indrawing. And on auscultation, bilateral wheeze and crackles were audible. On CVS examination, there is grade 4 by 6 systolic murmur with maximum intensity along left lower sternal edge. Apex beak shifted laterally, liver is also palpable and hepatomegaly is there. Another scenario is that a mother brought her 1-year-old child with complaint of net gaining weight and repeated attack of the respiratory infections. On examination, his height and weight are below third centile. He is pink and has pensystolic murmur at the sternal edge. Okay, so we have read all these scenarios. Almost these are 4 scenarios. So from these scenarios, we have guessed that in ventricular septal defects, the following features are present. That is, first one is that there will be pensystolic murmur. Then the second one is that there will be weight loss or malnourished history. Then okay, these are the 2 main things which give us a diagnosis of ventricular septal defect. Also, there is no clubbing or cyanosis, so it is a cyanotic heart disease. So from these features, we have make our diagnosis that this is the ventricular septal defect. Now coming towards the differential diagnosis of ventricular septal defect, these are VSD, MR and TR. The diagnosis of this scenario is VSD, and the clinical features or routine physical examinations on auscultation, what will be the findings? So in small VSD, we have the patient is usually asymptomatic and pensystolic murmur along the left sternal border is present. In moderate VSD, dyspnea, feeding difficulties, poor growth, sweating, pulmonary infection, heart failure may occur, and pensystolic murmur is present, which is loud. In large VSD, pulmonary hypertension is present, dyspnea, feeding difficulties, poor growth, sweating, and pulmonary infection is present. Heart failure, cyanosis, pensystolic murmur, which is less harsh. So these are the physical examinations or auscultation or clinical features that are present. The investigation options for ventricular septal defect are chest X-ray. In small defects, chest X-ray may be normal or show mild cardiomegaly and slight increase in pulmonary vascularity. In large defects, there is cardiomegaly, increased pulmonary vascularity, and enlargement of the left atrium and left ventricle is seen. With pulmonary hypertension, distal pulmonary arteries become smaller but proximal pulmonary arteries enlarge. Okay, the ECG is done for the VSD, and in small defects ECG is normal. In large defects, biventricular hypertrophy is seen. P waves may be notched or peaked. Right ventricular hypertrophy predominates when pulmonary vascular resistance is high An extreme left axis deviation is characteristic of the VSD in endocardial cushion region as in Down syndrome. So these will be the findings on ECG of the VSD, that is small defects, then ECG is normal in large defects. Biventricular hypertrophy is present. P waves may be notched or peak. Benign ventricular hypertrophy predominates when pulmonary vascular resistance is high, and extreme left axis deviation is the characteristic of VSD in endocardial cushion region as in Down syndrome. Then cardiac catheterization is done, which demonstrate the pressure and oxygen saturation in different chambers. Now the treatment options or management options for the VSD is that medical management is done, in which the patient with small defect reassure patients of benign nature of the lesion, child live normal life and may heal spontaneously. Large VSD control congestive heart failure to prevent the development of pulmonary vascular disease. Now infants with large VSD often fail to thrive, so maintenance of normal growth is impaired. The congestive heart failure is treated with digoxin, diuretics, and afterload reduction medications. If patient does not respond to vigorous anticongestive measures or shows signs of progressive pulmonary hypertension, surgery is indicated without delay. Okay, so these are the important measures which are done. Congestive heart failure, if present, then digoxin and diuretics are given, and afterload reduction medication is given. And if patient does not respond to the medical treatment, then surgical options are preferred, and surgery is indicated without delay. So the surgical options for VSD are the indications for surgery is intractable heart failure, pulmonary hypertension, and chronic volume overload. Failure to control congestive cardiac failure despite maximum medical treatment. Failure to thrive. Child within 6 to 12 months of age with rising pulmonary hypertension. Child with age greater than 2 years. Pulmonary blood flow more than the twice of the systemic. And supracrystal VSD, associated pulmonary stenosis and development of aortic regurgitation. If the following things occur, then surgery is indicated. The complications of VSD are congestive cardiac failure, repeated episodes of the respiratory infection. Okay, one point is also this one, that there is the repeated respiratory infections occur in the VSD. Okay, so repeated respiratory infection and congestive heart failure. Okay, growth failure, infective endocarditis, and pulmonary hypertension, and Eisenmenger syndrome, which is the reversal of shunt with cyanosis. So we have discussed the most important topic from the CVS, that is VSD. We have studied the scenarios, that what are the diagnostic points. So these are the repeated chest infections, the pensystolic murmur, the weight loss, and the clubbing is present. No clubbing or cyanosis, then this is the ventricular septal defect. Then we have discussed the differential diagnosis, the diagnosis and the clinical features, that what will be the clinical features or physical examination or on auscultation in small VSD, in moderate VSD, in large VSD. Then we have discussed the investigation options, which are of that of chest X-ray, ECG, cardiac catheterization. Then we have discussed the treatment management, that is medical management and surgical management. Then we have discussed the complications. Now in the next video we will be discussing the topic patent ductus arteriosus.